What I'm going to do is I'm going to very quickly go through a report interpretation, and then I am going to go through a little bit of estrogen metabolism and understanding that and understanding how to interpret the urinary results as far as uh, um, estrogen metabolism is concerned. And then we will jump into a Q&A session. If at any point you have questions during the webinar, you may always just type directly into the chat box any of your questions, and I will stop during the presentation to answer some of those questions so that everybody gets an answer to those questions. So without any further delay, I am going to jump right into the report. When you log in to your online account, most of you, if not all of you, should have received a link to your online account in an email. If you have any difficulty finding that link, we can send you another email. All you have to do is send an email to results@physicianslab.com or info@physicianslab.com, and then we can send that link back out to you. Once you click on that link, it's going to ask you to set up your password. Your username is already in the email. And when you log in, you're going to see a screen that is very similar to this screen here. And you're able to place orders and things like that. I'm actually going to jump into my physician screen right now. So this is how many, this is how many, sorry, I don't know why I keep saying how many. This is the order screen. This is my personal order screen. If I want to place a new order, I just click New Order. I put in the patient information, the email, the date of birth, their address, their phone number. Very important that we have their contact information. We ship the kits directly to the patient. There's no need for your practice to purchase anything ahead of time or store any kits in your office. When you place this order online, we contact the patient to verify that all of the information is correct. If you choose that we're billing the provider responsible for payment, then we don't talk about billing at all with the patient. If you choose patient is responsible for the payment, we'll actually collect the insurance information. If they have insurance, we'll collect the credit card information from them, and we'll handle all the billing for your practice if you choose. You have the ability to choose which type of payment the patient, whether we're billing your practice for the kit or billing the patient for the kit on every single order. So you don't have to pick globally. Every order you can choose whether we're billing the provider or the patient. And then regardless of whether the provider is paying or the patient is paying, we ship the kit directly to the patient every time. We also contact them to explain collection instructions with them. They get very comprehensive collection instructions in the kit, as well as color-coded times of day that are color-coded with the instructions. So it's a really easy ordering process, and all the physician needs to do is fill out this information, and then we handle the rest. Obviously, if the patient is a patient pay, we need the ICD-9 codes so that we can submit to their insurance if they're using insurance. Otherwise, if you're selecting provider pay, no ICD-9 codes are necessary. You can also change your username at the edit account or your password, email address, and so on. A lot of physicians like to change the email address to the contact of their office manager. That way, any correspondence that we send out goes to their office manager as opposed to them. Okay, so with that, I am going to open up a report. Now I'm going to open up my personal report. What you see is these report searches, which you have on your login as well, allow you to put any portion. My last name is Kosilova, but I can put any portion of my last name and pull up those patients. And I can sort by any of these blue links going across the top of the page. So I can sort by a session number. If I click it once, the arrow goes from smallest to highest. If I click it again, it goes from larger number to smaller number. So all of these can be sorted just by clicking the link at the top of that column. So I'm going to dive into this report here, and let's take a look at this. So the reports can be viewed in HTML version or PDF version. I find it a little bit easier during these trainings to go through the PDF, so I'm going to go ahead and open the PDF. So at the top of the report, we have the patient information, then we have the practitioner information over here. This information is in the order itself. There are collection times. I neglected to complete my collection time, so I apologize for that. If I go to one of my other reports where I did not neglect to complete my collection times, you see, oops, that's the same report that I just clicked on. You see that the collection times are present. These are patient-reported collection times from their questionnaire. Now, we make it easy for the patient to fill out their questionnaire, and what they're filling out in their questionnaire is their collection times. This information, this information here about the status of their periods, are they still cycling, have they had a hysterectomy, any ovaries removed. They're also indicating any hormones that they're taking, and they're filling out a very long, comprehensive symptom questionnaire, which is documented on the last pages of the report. So in jumping back, here it's indicated no menstrual cycles. Again, incorrect. I have irregular cycles. I didn't fill out my questionnaire for this one. I'm one of those non-compliant patients that we come across every once in a while. By the way, yes. By the way, with non-compliant patients, which we come across quite often, we actually contact those patients, remind them that they haven't completed the questionnaire. We'll actually stay on the phone with them and fill out the questionnaire with them on the computer. So we do help your practice in that nature in following up with the patient. We follow up with them not only on the questionnaires, but also on collecting, reminding them to collect, and really keeping in constant contact with them and guiding them through that process, mostly because our research has shown us that the time it takes to do the lab testing across laboratories is pretty common. You know, we can take 5 days to put out the lab results, 10 days to put out the lab results, but we're not really competing on how long it takes us to put out the lab results from the time we receive the sample. Where we're really competing is how long it takes us to get the sample, which traditionally is the longest time period between the time that the patient receives the lab order and actually gets the sample into the lab. So we manage that through contact with the patient. Anyway, back to the report. We've got the results here, and then we've got a cortisol graph, which I'll discuss in a moment, and then we have patient symptoms from the questionnaire that are mapped out in order of severity. So my high severity symptoms are first, my moderate severity symptoms are in the middle, and then my low severity symptoms are at the bottom. If the patient indicates that they do not experience that symptom on the left-hand side will not appear on the report at all. So, so if you're missing some symptoms, it is because the patient has not reported that they struggle with that symptom. Okay, from the results, we've got the profile categories, the tests inside that category, the actual results, the units, which are reported in micrograms per milligram of creatinine or milligrams per gram of creatinine. We relate all our results to creatinine clearance, and that is how we get away with having the patient collect 5 small samples throughout the day as opposed to a 24-hour jug. 24-hour jugs are very inconvenient for the patient. do not allow for us to get the 5-point cortisol throughout the day. That's really indicating adrenal function and how the adrenals are reacting to waking and stress throughout the day. If we relate our results to volume, we need to collect 100% of all the urine during the course of the day. If we relate it to creatinine, we can take these smaller samples. These smaller samples are taken from the bladder, which is a storage container, so we're still getting 100% of the values in the urine for the 24-hour period. We just don't need to get 100% of the volume in order to do so. Then our last column is the target range. Now, the target range is very different from most laboratories. Most clinicians are used to seeing reference ranges. Well, the definition really in a laboratory of a reference range is where 95% of every subject tested falls. It doesn't matter whether that subject is sick or well, whether they're supplemented or not supplemented. It's just where 95% of the patients in that lab being tested fall. We don't like to do reference ranges because the reference ranges really don't give a clear indicator at where the patient feels best or where the optimal health is. So we give target ranges which are more optimal ranges, where we like to see the patient and where the patient feels best. Now, none of these ranges in hormones can be looked at in a vacuum, right? So we need to balance our estrogen with progesterone, for example. So I can tell you that a patient who is not taking a progesterone supplement, this is a non-supplemented range, is going to feel best between 400 and 2,000. However, if that patient, like myself, is estrogen dominant, which I am, I'm not going to feel my best at a 2079 because I'm estrogen dominant. I need more progesterone in order to feel better. And so our target ranges are optimal, but we still need to use our clinical hat in order to, kind of look at these things outside of an individual test-by-test vacuum. So moving down, I'm going to go back to interpreting the results in a moment, but moving down to the graph here for cortisol. More and more literature is indicating that it doesn't really matter how high or low the cortisol is, or even what the median for the day is. What really matters is the pattern of the curve. And so here in this chart, we have the upper range of the optimal. The lower range of the optimal are these two gray lines, and then the patient is the blue line in the middle. And what you notice here is while I start a little bit low in the morning, I come right up to a good level in the mid-morning. In urine, this indicates morning levels, right, because urine is a storage container. So what I'm measuring here is overnight cortisol. What I'm measuring here is morning cortisol. What I'm measuring here is my cortisol mid-morning into noontime, even though when I'm collecting those samples has like a 3 to 4 hour delay. So what's really important is that I don't really much care about my AM being so low because my pattern is very indicative of a good adrenal response to waking up and going throughout the day. If I had a line that went right down the center here and then kind of gradually declined, that would be more indicative of adrenal dysfunction because I don't have that same curve shape. So important thing to notice. Now, getting into the symptoms, we talked a little bit about the symptoms, but one of the ways that they're also organized, not only are they organized in high severity from top to bottom, but each individual symptom is organized under the category by which they could, that symptom could be manifesting. So, for example, I indicated a high severity of allergies. The allergies can be contributed by low cortisol and by low androgens. So if I have low cortisol, that could be contributing to my allergies. If I have low androgens, that can be contributing to my allergies. But these symptoms are not integrated with the test results. These symptoms are simply where those symptoms could be categorized. And so that gives me the ability to kind of scroll down and see how many symptoms in these categories my patient falls into. And you can do it the way I'm doing it now by saying, okay, hypothyroidism. Well, I've got a couple highs, and I've got a few moderates, and quite a few moderates. And then as I go down into my low symptoms, I've got a few there too. I can also see that, you know, low cortisol and low androgens have some significant symptoms. I can do it that way, or I can skip right down to the last page, which kind of sums them all up. Now, unfortunately, when I filled out this questionnaire, I was struggling quite a bit with some symptoms, so a lot of the lines are very long, but you can very clearly see, you know, how many of those symptoms are affected. I like to bounce between the symptom pages and the results pages so that I can really pinpoint which symptoms are affecting the patient most and where I'm going to start in my clinical therapy. So here for this patient, which is me, I'm looking at estrogen dominance clearly, not only because of the high 15.4 in estrone, because I can't look at E1 or E2 or E3 in a vacuum, because in urine it's really all three and the levels of all three that determine my actual estrogen load. I like to call it the total estrogen load, which includes not only the 3 primary estrogens, but the 5 estrogen metabolites. And so what happens here is I'm well, you know, pretty good amount above the high end of optimal in estrone, and then I'm pretty close to the high end of target in estradiol, and also pretty close to the high end of normal in estriol. And then when I look at the metabolites, my strongest binding metabolite that inherits the most benefit and also the most benefit at the receptor, but also can contribute to those estrogen-dominant symptoms, is alpha-hydroxyestrone. And while I'm not really high in 16-alpha-hydroxyestrone, this is one of the strongest binding estrogen metabolites. And so all of these are feeding into this estrogen-dominant state that I'm in, combined with the fact that I have estrogen-dominant / progesterone deficiency symptoms here in my questionnaire. If I just go down the line, not feeling rested in the morning, headaches, anxiousness, cold body temperature, all these things that are contributed to by estrogen dominance or progesterone deficiency. So I'm not on an estrogen medication, so I can't lower my estrogen dose, but I can increase my progesterone. I'm not on a progesterone medication either during this test. So I can increase my progesterone to balance out that estrogen-dominant dynamic. I could stand to be a little higher in testosterone. I have low androgen symptoms. Most patients feel pretty comfortable around 23, and because I'm a woman who's 5'7", I don't want to be on the lower side of my 10 to 35. I want to be more in the average to above average side, because my height and my weight play a lot of role in what side of the optimal range I want to be at. If I'm a short woman with a very small build and very thin, I might feel okay right around 10 or 12 in testosterone. However, if I'm, you know, a 5'11" woman who weighs 180 pounds, I'm probably going to feel much better in the 30 to 35 range. So it's just something to keep in mind when we're looking at the optimal ranges and bouncing the hard values from the results, balance them against the symptoms. So here, if I were the clinician treating this patient, I would certainly increase my progesterone in this patient, and I would certainly be looking to support phase 1 and phase 2 detoxification of estrogen, which I'll get into next. The cortisol seemed to be okay, the DHEA seems to be okay, the DHT seems to be okay. These are all things that we look at. And so that's where I would start, based on the fact that the questionnaire and the lab testing is pointing me in the estrogen dominant and perhaps testosterone deficient area. So with that said, I am going to quickly open up the microphones for any questions. So if you have any questions before I go into the estrogen interpretation, please feel free to speak now. You are unmuted. Okay, I'm just going to move on then. I'm going to mute the phones again just so that other people won't be disturbed by background noise. Okay, so estrogen metabolism. So there is phase 1 detoxification of estrogens, and really phase 1 is converting our primary estrogens, E1, E2, and E3, into either 16-alpha-hydroxyestrone, 2-hydroxyestrone, or 4-hydroxyestrone. And I have a slide that actually kind of shows this a lot simpler. So I'm going to open up that slide really quickly. Nope. Going to the wrong screen. So I'm just going to leave it here on the screen like this. Hold on one second. My screen's going to refresh really quickly, and then I'll be able to show it to you. Okay, so here what we have is E1 and E2. We know that E2 is, the predominant estrogen that we measure in the blood. In urine, we need to look at E1, E2, and E3 because they really interconvert to one another, and quite rapidly, in fact. And so what we see in the urine is not only the global level of what estrogens were available at the receptor in the blood and at the tissues, but we're also seeing how that balance metabolized. And so estradiol and estrone kind of interconvert with each other pretty quickly in the blood and at the tissues. And then estradiol can also convert to estriol. We know that estriol is a great estrogen. It offers some estrogenic properties at the receptor, causes some cell proliferation and some tissue growth. However, it doesn't bind at the receptor for very long. When something binds at the receptor for a short amount of time, it doesn't really contribute to estrogen dominance. And the cool thing is that it competes with estriol and estrone the same way that progesterone does at the receptor to prevent patients from becoming, from feeling the symptoms of too much estrogen when there isn't a competing nature from progesterone or estriol. So estriol is pretty good, and once it's estriol, it pretty much stays at estriol. It doesn't really convert back. I mean, it can, but it doesn't really. And then we have phase 1 detoxification, which is E1 and E2 converting to one of these 3 pathways. Now, the best pathway is the 2-hydroxy pathway. 2-hydroxy doesn't bind very long, also has those protective properties that estriol has some other really great properties to it, isn't really harmful in any way. Now, however, if there is a high level of 2-hydroxy, too much of a good thing isn't necessarily always good, right? If I have a high level of 2-hydroxy, this is probably going to indicate that my patient is estrogen dominant, because we can't really create a lot of 2-hydroxy without having a lot of estrone and estradiol. So, the instance of having a lot of 2-hydroxy isn't harmful to the patient, but the fact that we have a lot of 2-hydroxy is indicating that we have a lot of its precursors, which are estrone and estradiol. The other 2 pathways, one of which is dangerous to the patient, which is the 4-hydroxy pathway, has been shown in the literature to cause cancer, converts to quinones that are actually carcinogenic, and then 16-alpha-hydroxyestrone, which a lot of people deem it as a bad estrogen. I don't see it that way. There are a lot of benefits to 16-alpha-hydroxyestrone, and although the benefits are quite good, it is a long, strong binder at the receptor and has been associated with estrogen-dominant symptoms. The thing about 16-alpha-hydroxyestrone and 4-hydroxyestrone is they're primarily created when a patient is in a state of inflammation. Now, 90% of the time, this inflammation is stemming from the gut. So if I have GI inflammation, if I have food allergies, if I have leaky gut, all of these terms that we hear a lot about in functional and integrative medicine these days, if I have a patient that's got a lot of GI inflammation, they're probably creating more 16-alpha-hydroxyestrone than 2-hydroxyestrone, or the level of 16-alpha-hydroxyestrone, the ratio of that 16 to the 2-hydroxyestrone is not what we would want it to be. We really want our 2-hydroxyestrone to be 4 times higher than our 16-alpha-hydroxyestrone. When it's no longer 4 times higher, then we start to see symptoms of estrogen dominance if our levels are decent. And we start to wonder if our patient has some form of systemic inflammation. Now, why in the literature do people get really hung up on an elevated 16-alpha-hydroxyestrone? Because there is a lot of study out there that is indicating, and a lot of literature out there that indicates that there is a low 2:16 ratio, meaning a low to 2:16 ratio means I have less than 4 times the amount of 2-hydroxy to 16-alpha. So the higher my 16-alpha goes without my 2-hydroxy going higher, the lower my 2:16 ratio becomes. So when I have a low 2:16 ratio, that is associated with a higher instance of breast cancer. However, there is no data that shows that 16-alpha-hydroxyestrone caused that cancer. In fact, there is some data to dispute the fact that there is some data in association with prostate cancer, in fact, that 16-alpha-hydroxyestrone is advantageous to a patient who has prostate cancer. So the 16-alpha-hydroxyestrone is not causing the cancer. However, 16-alpha-hydroxyestrone is a strong long binder at the receptor, causes cell growth. Now, the 16-alpha-hydroxyestrone is not particular on what type of cells it's reproducing. Sometimes it reproduces healthy cells when it is at a tissue that is healthy. When the 16-alpha-hydroxyestrone is bound at cell receptors in tissue that is not healthy, like a tumor, it will cause that tumor to grow like a healthy tissue quite aggressively. And so what happens is, I'm a patient. I have breast cancer. My breast cancer is maybe not even diagnosed yet, but my body knows that it is fighting something, and that I'm going into a state of inflammation. In a state of inflammation, my body produces more 16-alpha-hydroxyestrone, and through a cascading event, I get higher levels of 16-alpha-hydroxyestrone, causing my cancerous tissue to grow more aggressively. This is why we like to keep a good eye on 16-alpha-hydroxyestrone. We definitely don't want to start testing people for cancer who have a high 16-alpha-hydroxyestrone. That's not a good idea. Most of the time, like I said, 90% of the time, it's GI health. We've got some gut issues going on, gut inflammation, systemic inflammation. You know, arthritis can cause this type of reaction, but we want to clean up the patient's inflammation. We want to introduce B vitamins. We want to introduce antioxidants. We want to introduce methylated folate, all these things that support the pathway going down the 2-hydroxy pathway as opposed to the 16-alpha-hydroxy pathway or the 4-hydroxy pathway. Now, there's a saving grace if the patient is making 4-hydroxy or 16-alpha-hydroxyestrone. And the saving grace is phase 2 detoxification. In phase 2 detoxification of 4-hydroxy and 2-hydroxy, we have the COMT, which is methylating our 4-hydroxy into 4-methoxy. and methylating our 2-hydroxy into 2-methoxy. The cool thing about 4-methoxy is that it completely neutralizes the carcinogenic effects of 4-hydroxy. So 4-methoxy does not cause cancer. 4-hydroxy can. 2-hydroxy doesn't cause cancer anyway. However, 2-methoxy, a methylated 2-hydroxy into 2-methoxy, can reverse the damage of my 4-hydroxy, can protect my tissues from the 16-alpha-hydroxy, and can slow tumor growth in an existing tumor. So the more 2-methoxy I have, the healthier my patient is, the better off I am. My phase 2 detoxification, which is basically methylation, so we're getting to that with DIM supplements, with methylated folate again, with any kind of methyl donor supplement, cruciferous vegetables, exercise, all kinds of things that are really going to benefit the patient. Most of these changes actually occur through lifestyle changes. There's a lot we can do with supplements. There's a lot we can do with medications, but a lot of these changes in metabolism are directly related to lifestyle. And so now you have a nice test that's directing your patient on exactly what they need to do to protect themselves against their estrogen profile, their metabolism profile, like I like to call it. The other saving grace for 16-alpha-hydroxyestrone is not only does 2-methoxyestrone protect the tissue against rapid tissue growth and protects the tissue against 4-hydroxyestrone, but it converts into estriol. And when I see a 16-alpha-hydroxyestrone that's elevated, but also an estriol that's elevated, like my own results, going back to my own results, I see a 4.7 in my alpha-hydroxyestrone. Now, this is not an elevated level in a vacuum by itself because my reference range is 0.2 to 15. However, my 2 to 16 ratio is not I don't have 4 times more 2-hydroxyestrone than 16-alpha-hydroxyestrone. I barely have 2 times. I have 1.7 times more 2-hydroxy to 16. So my 2 to 16 ratio is low. One of the best things I can do when my 2 to 16 ratio is low is protect my receptors and increase methylation. I'm going to increase methylation. I really want to have at least 25% of my 2-hydroxyestrone number in 2-methoxyestrone. So I really want to have at least 4 times more 2-hydroxy to 2-methoxy as well. So when I'm looking at this, I'm saying, okay, I really need to protect my receptors from this 16-alpha-hydroxyestrone because of my low 2 to 16 ratio, and I really need to increase my methylation. My methylation is going to protect any cell growth that's happening too rapidly with my 16-alpha-hydroxyestrone, and my 16-alpha-hydroxyestrone is converting to this nice 19 that I have in estriol, which is giving me an E quotient of 1, which is optimal. At least 1 is optimal. Anything higher than 1 is just great, because my estriol is now competing at the receptor with my E1, with my E2, and with my 16-alpha-hydroxyestrone. So 16-alpha-hydroxyestrone has this nature about it that it converts to estriol, which then competes with 16-alpha-hydroxyestrone to prevent the estrogen-dominant effects of 16-alpha-hydroxyestrone at the receptor. So that is basically that whole cycle. We've got primary estrogens basically indicating to us how much estrogen is available to the patient. So this is where your dosing comes in, right? Your dosing level, so to speak. But you really do want to pay attention to the 16-alpha-hydroxyestrone in your dosing levels too. You can indicate that a patient is estrogen dominant by how much 16-alpha-hydroxyestrone they have, as well as E1, E2, E3, and to a certain extent 2-hydroxy. Because remember, if I have too much 2-hydroxy, it may indicate that I'm estrogen dominant in my primary estrogens, but that I'm metabolizing them very quickly. So my patient may not feel the effects of that, which is great. But my patient doesn't necessarily need more estrogen if that's the case. So my phase 1 detoxification, supported by reducing systemic inflammation, introducing B vitamins, antioxidants, methylated folate, all these types of things. This is great too. Phase 2 detoxification is DIM supplements, I3C, an SAMe type of methyl donor supplement, changing lifestyle, getting more exercise, not ingesting high levels of caffeine. Caffeine throws this whole balance off. All these different types of things that throw this balance off. This phase 2 detoxification is really great for your patients who have MTHFR mutations. They're not great methylators, so supporting phase 2 detoxification is going to make them feel so much better and is going to lower their risk of cancer. And this goes for patients who are on supplementation and who aren't on supplementation, and that's why I focus on it a lot. We definitely want to make sure that our patients are hormonally balanced. So all the hormones are going to help us do that, but then we really want to make sure that our estrogen profile, as well as our estrogen metabolite profile, is really showing that the patient is living a lifestyle and is getting the therapy they need to not only benefit from the positive effects of estrogen, but protect themselves from any of these pathways that can lead to cancer or can lead to rapid cell growth. So with that, I'm going to open up the phones again for any questions, or you can always type a question directly into the box. So do we have any questions at this time? Okay. So what I'm going to do now is I'm going to invite you to just get to my last page of my presentation quickly. Oops. I went all the way through it. If you have any questions about testing, if you have any questions about ordering, if you have any questions about, you have a patient in front of you, you've ordered the test, you've got the result, and you just don't know what to make of it, we are always available for help. I'm Stacy Kosilova. I walk everybody through the report interpretations and the science side of it. Lee Rolnick is your business resource, so you can call the 800 number and ask for us specifically, or just let customer service know what your specific questions are or where you need help, and we're here to help in any way possible. And I thank you for joining, and I'm going to turn it over to Lee.
Again, thank you very much for attending the webinar today. We're going to send everyone who attended the slides from today's webinar. And again, if you have any questions whatsoever, please let us know.
Yeah, and we'll also send out an estrogen interpretation guide, as well as a talk performed by Jennifer Landa in the benefits of methylation in all health aspects.
All right, folks, if you have any questions, if you need anything, please let us know. And this concludes our webinar for tonight. Thanks again for taking the time out of your day. We truly appreciate it.